Welcome to Wound Care Matters podcast, brought to you by Medit UK. Join us as we take a deep dive into the world of wound care. So welcome to our fourth episode. It feels like eons ago since we did the last one. I'm more than happy to admit, though, that this is probably one of my favourite ones and the one I've been looking forward to the most. In this episode, we'll be discussing the care and management of malignant wounds from a specialist point of view. And our very important guest today is Susie Pramud, lead tissue viability nurse at the Christie Hospital in Manchester. Me and Susie have known each other a very long time. We worked together when I was a tissue viability nurse at the Christie many moons ago. And we do both share a huge passion for the holistic assessment and management of malignant wounds. So tune in as we discuss the challenges, insights and successes of this complex, often frightening area of wound care. So welcome, Susie. Good morning. Thank you for joining us. It's lovely to see you. How are you?
Good morning. I'm doing well, actually. Yes, it's
Good.
really a good day out here today, to be honest.
That's always good. A bit of a positive start to the day. So obviously, you know, me and you have known each other a long time. We both know each other well. We know how each other works and we know how we both sort of work within our clinical capacities. But could you start, Susie, by giving us a little bit of a brief background into your role at the Christie, what you do, and a little bit about your background interest into malignant wounds?
Okay. Yeah, my background, wound care background, goes back to 22 years ago when I started to work in UK. So I started my career in oncology nearly 10 years ago when you started your tissue viability service here, to be honest. Which made me to think when I started my job in the oncology, made me to think all the wound cares are going to be similar. But when I started to see patients on the ward, I realized malignant wounds are totally different. Maybe management underneath basic care, probably right, but you really need to think of what you are exactly trying to do to this patient, how you are going to help these patients. So when you dragged me into the tissue viability.
Kicking and screaming.
Yes. And then I was thinking I'm not going to like it, but see, I'm here as a lead nurse for tissue viability now. But when I started to see patients with a malignant wound, really my heart sank. And how these patients actually living with it when they wanted a little bit of help sometimes to go out to the pub for a drink. The dressing which stays well for 2 hours probably. Those are the things really resonate with me. And some of the time we see the quality of life of these patients. Their quality, maybe they just want, as I said, they want to go for a drink or they just want to go to the shopping so that nobody else recognize the smell part of it or the symptoms. They sometimes they express as a disgusting smell coming out from their body or flesh eating away from their body. Those are the things they explain to us. So they really wanted a little bit of reduction in their symptoms, which they can actually go into, which can help them to improve their quality of life. That's where my passion started when I thought if I'm working in an oncology setting, if I don't look at it in detail and do some research, what are the available caring modalities are there or what are the different types of dresses could help these patients to manage. I went in to do some research internship. Initially, I started with the research internship. I know Sharon has done the research internship, which has actually brought us a document or pathway which helped us with the POSI pathway, which given us some information how we can start looking after these patients. So I did use the POSI pathway, and that was a great resource when I started the tissue viability service. Then I also wanted to go into little bit more research in this area, so I decided to my pre-doctoral fellowship, hoping to continue with my doctorate. But pre-doctoral fellowship has given me a great idea, great information how people with the malignant wounds are actually managed across the UK at the moment. As part of my pre-doctoral fellowship, I actually did a survey among the nurses who care for the people with the malignant wound. So I came to understand what is out there, and similar to what we use at the Christie's, and I also did a scoping review, which has given me really interesting information. What are the evidence? The evidences are scarce, and it is really very under-researched area. And I'm so glad to see that it is this important aspect of this patient life and care is coming up to light at this point of time. And past couple of years, I have been seeing more teaching about the wound care. Malignant wound care is there in the across the UK, and I also presented in Europe in a wound management association conference, which really nice to see that everyone is embracing, everyone wants to learn. This could be again after the COVID, there was a
Yeah.
surge in referrals.
Yeah.
We had double amount of referrals from the previous year after the COVID,
Yeah.
which really shown that how is this COVID has impacted the patient,
Yeah.
and people were not going out to see the patients, and they were scared to come out to see the physicians or clinicians. So that was another reason I thought.
Yeah.
And COVID has really brought this problem into the sight of everyone actually, and which and I can see in the recent couple of years there are more research in this area.
Yeah, absolutely. And that's the thing. We're going to see this for years, aren't we? That sort of backlog or that outfall from the COVID pandemic when, like you say, patients were scared to leave the house. Patients were sat on symptoms that probably they wouldn't have sat on before. They'd have reached out to a healthcare professional, but obviously didn't because of fear of COVID. And then, like you say, it's what we're seeing now as the sort of backlash of that, really.
Actually, yes, that's true. And also, I think, I mean, everybody was at home. Now people are coming out. Then they are probably realizing these disgusting symptoms are really putting them down to come out. That's
Yeah.
another reason they don't want to report themselves. That's a social aspect of it is as well, isn't it, when they come out?
Yeah, absolutely. They're socially isolated, aren't they? They feel that they can't. And I obviously remember from patients, and we'll probably be able to think of patients that we both looked after at the same time. They are so socially isolated. They are dealing with so many different symptoms. And interestingly, one of the things that you said at the very beginning was that heart sink feeling of clinicians. And it is. And obviously, we've got a session planned at Harrogate at Wounds UK conference. And we've asked delegates, haven't we, to send in that one word that they think about. So one word that clinicians think about when they think about a fungating malignant wound or a malignant wound management. And heart sink is one of the words that somebody has sent in. So, you know, clinicians, they do struggle and they do want to do the best. We all want to do the best for our patients, don't we? And it's those things, like you say, that we take for granted that patients with these complex conditions can't do, like go to the pub or socialise with family and friends.
Yeah.
I got asked yesterday a question that I'd never really thought about, and I don't know whether you've ever thought about it, but obviously because of our passion, we both talk quite freely about malignant wounds. We perhaps don't have the same level of heart sink that we used to. We may well have because we see the distress it causes patients, or it can cause patients, people, family members. But I was asked, what was that turning point in your career? What made you feel no longer scared? Or, you know, what was that light bulb moment for you, Susie, in terms of managing malignant wounds?
I think when I came to know how I can help this patient, so asking the patient actually what they want us to help with, because I think sometimes, oh, the order is the major problem, but it may not be. It's the exterior, it may be a problem. So when I know that I have got the tools in my box to help this patient,
Yeah.
that probably the time I understood, right, I can help this patient now. When a new staff goes in to see a patient, it is a terrible feeling they have, and I remember there are still cases might take that, but when you come out from that patient satisfying their need, what they want. I had a recent patient, you will always have patients. They wanted to put a dressing on. The mother was caring for the patient, so she wanted a easy dressings to go on to this wound, which she can manage herself. So I knew what I can do, how I can help her. So that was a good point for her. So she is not distressed going around trying to find the solution for it, not trying to find the resources for it. So then when I advised on that and I have showed her, she was very grateful, and she was happy with that, and she is not spending hours to do the dressings for her daughter. So I think my turning point, probably I'm equipped with, I think the research and learning and all the practical aspect of it and the skills I learned over these 10 years probably has helped me to help these patients. I know I can actually do this for my patient if I can think out of the box. There are quite a lot of dressings which is not fit for these wounds, but you have to think out of the box to fit all this to the patient. So that's probably the time I thought, whichever case, whichever way it is, I'm sure I can help with it. But the new staff or the people in the other area may not have been exposed to this, and there is no education or no training in this aspect. That's the major issue with for other people to manage.
Yeah, absolutely. And obviously you mentioned the Posies pathway, and we can pop a link attached to the podcast for people to access any of the information that we discuss in this episode. But the Posies pathway was obviously developed originally by myself and a colleague, just to help clinicians to assess the symptoms of a malignant wound holistically. So do you want to just explain what some of the acronyms in the Posies stand for?
So yeah, I can do that, because one of my research, my survey also showed that what the most difficult symptoms patients actually found it difficult to manage. One is the pain. That is the one stands for POSI. So the P stands for pain. So when we think as usually when you care for the patient, you probably think pain is not something the first one, but we realize that in the hospital this pain is well managed because our supportive care team are involved with this patient. But when you are in the community, that may be one of the most difficult symptom to manage. You cannot touch the wound, it's very painful, the surrounding area may be very painful. So that's the pain management in POSI, and it just shows you how to assess the pain. Maybe there are various scales you can use to assess the pain, and there are various methods you can use to help the patients to reduce the pain before you do the dressings. I'm not going to explain all the aspects of that.
Yeah.
And O stands for order, that I already mentioned. This is really difficult for the patients to manage. And again, you look at the management of the order, or you look at how to assess the order. So there are different scales again you can see, but the simple scale probably which you have to use when you enter the ward, whether you can smell, that will be 5. Then whether you can go to the nearer to the room, whether you can smell, or you can when you go closer to the patient, when you take the dressing off. So those are the level of assessment you do. So again, managing the order is very, very important. And I had a patient recently which we managed the order very well. And there are various management plan. I think this won't be enough for us to, this podcast won't be enough for us to explain all those things. So when the order is managed, patient's quality of life is improved. And which was again testimony from one of my patients. She was actually telling me she didn't let her children come in, and the children didn't want to go into her home, and she didn't invite anybody to home. But so after certain type of modalities of treatment we tried, she was happy to come out of the room. The children came nearer to her. Those are the real testimonial patients come out with. So that's the importance of managing that clearly. And then S stands for skin. What is this? Oh, Sharon, I have got a mental block.
You're having a mental block. So yeah, so S is for surrounding skin.
Surrounding skin. That's what I thought. Then I thought, oh my God, that's a...
You were just making bits up as you go along.
yeah. And then surrounding skin. Okay, I always tell my staff to use a contact layer so you don't peel the skin off, and using an adhesive remover to remove the dressing is most important. How much it will take us to use adhesive remover to take the dressing off. And using a barrier film, so that again protecting the surrounding tissues. And again, all this comes in your assessment. And then you look at the infection. I stands for infection. If you swab any of the malignant wound, you'll come out with lots of bacteria living in it, isn't it? So there is no point of swabbing in unless there is a sign of systemic infections. Otherwise, please don't swab the wound. You are not going to treat the swab. You are going to treat the patient, isn't it? So again, topical antibiotics seems to be working well with this, and that will all the symptoms like a pain, exudate, infection, all interrelated. So you just need to treat the infection. Is a localized infection, then that will reduce the exudate, that will reduce the pain. All those aspects are really important to see. I'm trying to see post-C.
E for exudate and bleeding.
So exudate, again, heavy exudate. Some wounds can have a heavy exudate, and which is very important to capture within the wound. As soon as the wound started to leak out of the wound is going to cause more maceration around the skin. And again, it's not comfortable for the patient. They have to change so many clothing. Might have to change their bedding very often. Those are the other things patient wants a little bit of comfort, because if they don't need to change the dressing very often, that itself will be helpful. So depending upon the exudate level, they should actually use the type of dressing. And some of us have some of our colleagues think actually, even if this wound is not exuding heavily, they want to change the dressing every day, which is not required.
Exactly. And it's just a habitual practice, isn't it? If it doesn't need changing, don't change it.
And actually you are causing more pain taking them off, and exposing the nerve endings to the atmospheric temperature is going, all that negative impact on changing this dressing needs to be checked. So I always say, if the exudate level is not very high, you don't need to actually change this dressing. The same thing, if the exudate level is high, some patients dressing may have to be changed twice a day. So that's a different scenario. And other major issues, bleeding. And this wound can bleed very easily. And if there's a start of a minor bleeding, can cause, if patient had a minor bleeding, which they are at risk of 4 times high risk of developing a severe bleeding anytime in their life. So it is important to ensure we don't cause any bleeding, because dressing removal can be painful. That can cause damage to the skin. So ensuring all the non-adherent dressings for this wound are more important. So that's and then there are various pathways for bleeding management. You can use various products are available, which we can talk about it when people come to Wounds UK conference. And that's and then POSI is actually self-care and the social aspect of it, isn't it? So it's very important to understand the patient's social aspects and giving them the support.
Absolutely. And it's like you said about those patients that want to do things like go into the pub and seeing friends. I spoke to a clinician recently who'd cared for a patient with a malignant anal tumour, so large tumour from this patient's anus, and the patient just wanted to be able to wear tight-fitting jeans. That's all she said. I want to be able to put my jeans on and go out with my children and my family. So, the clinician worked with the patient and the family to come up with a dressing regime that they could manage themselves, that allowed her to be able to wear the clothes that she wanted, and that gave her that that enhanced quality of life with her children and with her family at the last days of her life. And just being able to put your normal jeans on, that is all that mattered to her. And it seems like nothing to us when we open our wardrobe and get dressed in the morning, although if I keep on eating the amount of cakes and stuff I'm eating, it might be a problem for me. But those simple things that we take for granted, that's all that she wanted.
Absolutely. And as I said, they probably want the child to come near to us,
Yeah.
and we wanted to hug the children. All those things are most important. And then if they want to go out or invite people home, those are the very, very important aspects they probably want. And we really need to be conservative. Sometimes you think, oh, I'm doing this dressing for you and you should be happy, but it's not. You need to think of the patients. And you know what, they are already suffering with the cancer, and
Yeah.
this is extra as another additional wound they have to deal with. And if you look at their emotional journey with coming into this, and they are drained, they
Yeah.
haven't got any sources to go and tap into, and this will be your chance to help this patient. And I always feel, how, I mean, if it is for me, how do I want this to be treated, how I need to be cleared of this.
So obviously, like we've said about, you've done loads of research. I did a little bit of research. You've done so much work and you should be massively proud. And I know the conversations that we had over the past couple of years with your predoctoral, you should be so proud with what you've done. But what now? We know that there's so much more research needed in this field of wound care. What are your plans now?
I mean, one of the things I'm proud of, actually, Sharon, you putting this together for the consensus document, which is coming out, which has published, which is coming
Yeah.
out to Wounds UK, and that was my dream, to be honest. And then, because it's not because people are disturbing me, I get constant emails asking about the patient. They send the patient for patient wounds pictures to say, can you help me with this? So that is something for their toolbox, which they could use very well. And I'm really, really glad that has come out. But I think I'm also doing my third year masters, which I really want to focus on fungating malignant wound. Actually, that's what my passion is. So my supervisor agreed with me.
Do you remember when you
I,
said you were doing no more studying?
I know. And okay, and I think it's dragging me into it every time when I do something, and I think, right, I need to do this now. I think it's very. I think it's because I have got the passion. I really
Yeah.
like to do this. That's that sort of scenario I'm thinking. And then I know now what the treatment management plans are out there from my scoping review, my survey. But now I want to know what the nurses or what the
Yeah.
clinicians go through, what is their experience caring for these people. And we can remember when we saw the first patient,
Yeah.
how you felt, how it is taking. And then that's one of the things I'm going to do with my master's registration. That's one thing I'm going to do. And one of the other thing I always had in mind when I was doing my pre-doctorate, I want to do some PPIE work, which I think I always feel, oh, the wound is exuding. That's what they want me to manage. But that may not be the thing patient wants to
Yeah.
do. So
Yeah.
what the patients and the relatives priority, that probably will help us to understand that.
Yeah.
Those are
And
the
like you say,
two things
it's
in my
often
head.
different to ours, isn't it?
That's true.
Often different.
Yeah, these are the two things in my mind. And hopefully I'm thinking hopefully I'll stop, but I probably will do more.
Just keep going while you can. Just keep doing this. It's amazing.
Thank you.
So obviously, we've both briefly mentioned the consensus document. So we were part of the expert panel group along with some other amazing expert panel members from the UK, and we also had a member from Australia, which was fantastic. So we have worked with Wounds UK to put together the consensus document around managing malignant wounds in practice, and we are both so proud of that, aren't we? It is like our baby. Again, we'll link it to the digital link to the podcast, but myself and Susie will be at Harrogate. We will be talking on the main stage on the Tuesday. So please, if anyone is listening to this podcast and is interested in talking in more detail around clinical cases, experiences, sharing of best practice, please do come and watch our session on the main stage, and then you're able to come back and speak to us on the Mediq stand as well, because we will have paper copies of the consensus document. And we'll also have copies of the POSES pathway if anybody wanted to look at that and discuss developing that for trust specific, because obviously, although the original POSES pathway was written by myself and Catherine Taylor, you've obviously developed it to suit your clinical needs in trust, Susie, and that's obviously absolutely fine for other clinicians to do. So please do come along. And like Susie's just said, really around that importance around managing or supporting, I don't know if they're the right words, but clinicians, how clinicians feel and how clinicians are in terms of managing these types of wounds. I can still remember the day when I realised that a fungating wound, so a fungating malignant wound, was like no other. And like you say, patients are often so desperate. I remember a patient being referred to me, and this patient was like, "Oh, you're the specialist nurse, you're going to heal this wound." And I was like, oh my God, I am not going to heal this wound. I'm going to support this patient and manage those symptoms of that wound. But ultimately, you know, this is a tumour that's infiltrated the skin. It's like no other wound. And I think just realising that or learning that makes you, as a clinician, approach these types of wounds and approach these patients very differently, and as we should be.
Yeah, I think you really need to compassionately approach these cases, because I know we all have got big workload, but I think these patients will take a long time. I mean, they probably want to come out to you to talk to things, but then you'll find that I haven't got time. But I think you should spare a little bit of time for these patients instead of, I mean, I always say, when I get a referral for moisture damage, you should be managing on the ward yourself. Let me just go and see this poor patient who needs me a little bit more time, and that's what I want to do. Because I mean, speaking to them, getting that rapport itself will help the patients. They know, and I always give them my email address or the phone number, and that little bit actually help the patients. They know if there is an issue, I can email you, I can call you, you are there at the end of the phone to help me. So probably sometimes we may not be able to do much. They have to continue with what we have already put in place, but that assurance there is someone out there who can help me. That's the most important thing.
Yeah, absolutely. And that's what patients need, isn't it?
Yeah.
I think it's probably really important that we say, obviously, this is a podcast discussing our clinical experience, our clinical, background and stuff with patients. We're obviously not giving out any kind of clinical advice on the podcast, but like you say, there are lots of resources out there now to support clinicians when obviously assessing holistically these types of patients, these types of wounds. And like you say, there is further research going on, which is absolutely amazing. It's so good to have a spotlight on this area of wound care, which is so important, so needed. And, the training sessions that we've both done, the webinars we've done, the amount of people that attend them speak massive volumes around the need for an understanding. One thing I will say, obviously, if you are a clinician listening to this podcast, I think it's really important when we're talking about malignant wounds to just always as well have in the back of our mind, if we are treating a wound, irrespective of what we believe the etiology or background of the wound to be, and the wound isn't responding as it should with the best sort of treatment and care plan in place, always make sure we're not missing any red flags. Always make sure that we are considering whether this wound could be atypical, could be a malignancy. So always making sure that irrespective of what we believe the wound type to be, that full holistic assessment and reassessment is done to make sure that we are providing the best evidence-based care for these wounds to help them to heal. If they don't do what we believe they're going to do or what they should, then always consider a differential diagnosis. So thank you so much for your time this morning. I know how busy you are. I know how much you've got going on at the moment. And I really, really appreciate you joining us to discuss your passion, your experience, and I think you're amazing. The stuff that you're doing, and we bounce off each other, don't we, when it comes to things. So thank you for your time. Thank you for your time joining us. As always a pleasure. Me and you could talk for hours about these kind of topics.
Good. Yes.
Thank you so much, Susie.
No problem at all. I'm so glad I could spare a little bit of time about this important aspect of care special needs.
Thank you.
Thank you.